Welcome to the FH Global Summit. For those of you who are joining us for the first time, this is our 8th annual FH Global Summit, although the first year that we're doing it virtually. I am Dan Rader, the FH Foundation's Vice Chair and the Seymour Gray Professor of Molecular Medicine and Chair of the Department of Genetics at the Perelman School of Medicine at the University of Pennsylvania. I am co-chairing this summit alongside Dr. Josh Knowles, who you'll meet in a second, the Chief Research Advisor for the FH Foundation and an Assistant Professor of Medicine at Stanford. Before we begin, I wanted to make a few announcements. I'd like to remind you to please use the chat feature on the bottom of the screen to introduce yourselves. Tell us where you're from if you're a clinician, scientist, or a person with FH. We have a great mix of thought leaders from around the world and people impacted by FH and heart disease. Please remember to change the setting to panelists and attendees if you want everyone to see your comments. We'll take all questions via the Q&A feature at the bottom of your screen, so please remember to use the Q&A function after you've introduced yourselves. I'd like to announce that the FH Foundation is very proud to announce the launch of a new website focused specifically on lipoprotein A, or Lp(a). The FH Foundation Board of Directors and leadership made the determination about a year and a half ago to begin focusing on Lp(a) as an important genetic risk factor for heart attacks and strokes, and of course, very important in the setting of FH. While there is an overlap between high Lpa and FH, with about 30% of individuals with FH also having high Lpa, we believe it's critical to address those whose risk is caused by Lpa separately. This is a huge unmet need, with over 66 million people in the US and 1.5 billion people globally affected by substantially elevated levels of Lpa, putting them at risk for cardiovascular disease. We also have a new support group on Facebook for those who are interested in this topic. The website is now available at www.familylipoproteina.org, and the discussion group can be found through the Foundation's Facebook page right now. The last announcement before we kick off this really exciting session. Before COVID-19 changed the course of 2020, a critical paper was published in JAMA Cardiology. It appeared in the February edition, the title, Reducing the Clinical and Public Health Burden of Familial Hypercholesterolemia, a Global Call to Action. This is both a nod to all the work of leaders like Roger Williams and all his global colleagues who recognize the important role that genetics play in cardiovascular disease and FH, especially in younger populations 2 decades ago. Their efforts resulted in the World Health Organization recognizing FH as a public health hazard and one of the first genetic conditions that could also be a winnable battle. The FH Foundation initiated this analysis of what had been achieved and sadly what had not been achieved in addressing the risks and applying our knowledge to prevent disease in those born with FH. The FH Foundation convened over 40 advocacy organizations who participated in this effort to develop 9 recommendations for improving FH care. Many of these individuals are on the call today, and it is a fitting tribute to the work we have all done together as an FH community to close the gaps in care for FH. We've recently made a summary document available, now translated into 20 languages, downloadable on the URL as you see. Finally, the FH Global Summit series would simply not be possible without the generous support of our corporate partners. The FH Foundation especially thanks Esperion for being a foundation-level sponsor, and all our corporate partners listed here for their commitment to advancing the diagnosis and care of FH, homozygous FH, and lipoprotein A. And now I would like to hand the baton over to Dr. Josh Knowles, who will introduce this session. Josh?
Thank you so much, Dan, and welcome to all the folks that are joining us from around the world. It's really great to be doing this second session of the year. Today's session will focus on unlocking the potential of precision health for diverse populations. Familial hypercholesterolemia impacts over 34 million individuals worldwide of all races and ethnicities. And for persons with FH, the diagnosis often comes too late and treatment needs to be more aggressive. Fulfilling the promise of precision medicine depends upon greater inclusion of diverse populations at every step along the way from bench to bedside. People of color are less likely to participate in research and less likely to get the care they need. Women are less likely than men to receive guideline-based recommended treatment or achieve LDL cholesterol goals. But more than highlighting the challenges, today's session really aims to highlight some of the possible solutions and pathways forward. We've dedicated the bulk of our time together to a roundtable discussion, and we hope all of you will be able to participate in this. And now it gives me great pleasure to introduce Dr. Latrice Landry. Dr. Landry is a fellow specializing in precision medicine and health disparities at Harvard Medical School, Brigham and Women's Hospital, Dana-Farber Cancer Institute, and the Harvard School of Public Health. As a clinical geneticist, epidemiologist, and nutritionist, Dr. Landry is focused on engineering of equity-based systems for clinical integration, translation, evaluation, optimization, and implementation. She's helping to lead equity and disparities research in the field of precision medicine, precision nutrition, and precision public health. Thank you so much, Dr. Landry, for joining us.
Thank you, and thank you for the invitation. I'd like to start today by talking a little bit about what I think is the roadmap forward. As we talked a little bit about disparities, and we've often had these conversations about disparities as well as equity and how we create that in our health systems, and specifically in this era of precision health and precision public health, precision medicine, all inclusive. I think it's important to think of disparities as really sort of understanding, or our approach to, or focus on disparities as an approach to understanding our landscape and really thinking about how we can have a roadmap forward. We're not, sometimes when we look at the disparities research, we often get disappointed about where we are in that sort of our overall landscape. But I think it's important to think about and feel empowered about where we can go. And I hope to share that with you all today. The title of my talk is The Pursuit of Equity and Precision Health for Familial Hypercholesterolemia. And I'd like to start at really sort of setting a foundation of how I think about this when we talk about precision health, and specifically what we'll talk about in the context of FH. So when we think about disparities, and we often talk about disparities, and as I mentioned, the current landscape that we have, I think it's also important that we become comfortable talking about exclusion as well as inclusion as the alternative to that. Structural racism, which includes both de facto and de jure practices. So sometimes when we think about structural racism, we get a little bit uncomfortable. But sometimes the structural racism essentially is biased in the system, and we need to understand it, and we have to address it if we want to change that. I also want to think about change, and a key word here is transformation. And then we can sort of think about that on the end. We'll talk about equity and what that transformational change can look like. So disparities. So we've all talked about heart disease. You guys are very familiar with sort of the landscape of heart disease. And specifically with heart disease, we have often talk about disparities, but in the context of disparities, it's important to separate two key issues here. So when we talk about prevalence of heart disease, and this information is presented to us from the Centers of Disease Control, it's important to understand that although there are differences in the prevalence of heart disease across populations, and here we have in this very nice infographic from the CDC, that we can see that the prevalence of heart disease in non-Hispanic white adults is about 11.5%. The prevalence of heart disease in non-Hispanic Black adults is about 9.5%, and in Hispanic adults is about 7.4%. Here, when we think about disparities in heart disease, the disparity is not in the prevalence. You can see that African Americans, who are traditionally thought to have a disparity in heart disease, have a lower prevalence. And so here, it's important to clarify our language. But if we look forward into the mortality rate from heart disease, And so this is another infographic from the CDC outlining the mortality rates from heart disease by population group. Here again, looking at Black non-Hispanics, white non-Hispanics, Hispanics, and this slide also includes Asian and Pacific Islanders. It's important to see here that we have a clear, persistent disparity in mortality from heart disease. And I think it's important to understand that this disparity has been persistent over time. And although in this we can see that trends are decreasing, so death from heart disease is decreasing in all populations, the disparity has been relatively consistent over time. And I think that's what we want to think about. In precision medicine and precision health, we're thinking about these great new tools we have to customize care and improve health of all Americans and all global populations. So how is that improvement going to also eliminate the disparity? I think it's important to think about this in the context of precision medicine and precision health as giving us tools by which we can treat individuals and also help and improve health in populations. And I think that where I see this in an equitable approach on the outset of our successful implementation of precision medicine 20 years from now, we will have eliminated this disparity in mortality. I think it's important to also think about when we think about cholesterol and heart disease, and heart disease, it's also important to think about stroke. And I wanted to show this because the persistence isn't just over time for heart disease. We also see this persistence in higher rates of mortality for African Americans. And here we have Black and African American and non-Hispanics in light blue, or sort of the aqua, the line that is clearly separated from others. And then we have the other populations, again, American Indian, Alaska Natives are included here, Asian Pacific Islanders, Hispanic, Latino, and white non-Hispanics. But here you can see that clearly, again, African Americans have a much higher mortality rate from stroke compared to other ethnic population groups. Again, it is persistent over time. And the importance of what we're doing here today is thinking about how precision health can create equity, how can eliminate this disparity in mortality. I'd also like to think about exclusion. So we often talk about, in my line of work, when we think about equity, we usually pair that with the word inclusion. And we don't often talk about, if we need to focus on inclusion, it means that we have a system that, for whatever reason, has excluded individuals. So we also need to think about exclusion. And this is why I want to think about this in terms of FH. So here we have a study that's focused on, this is a pan-national study that looks at FH across the globe. And of course, this is specific to this study. And so we have individual countries that were a part of this study. And so in this global research study that had 5 countries or 5 regions that were involved in it, we can see that in terms of the percent of patients that they were able to successfully diagnose with FH, right? And that's the key here is early detection and diagnosis using biomarkers and other things. We can see that in yellow, which is the highest rate of diagnostic, the highest diagnostic yield, versus blue, and sort of the bright blue, which is the lowest diagnostic yield of all of the countries that participated, we can see that the highest diagnostic yield is in the United Kingdom, in Europe. The lowest diagnostic yield is in Asia. And I think the key thing here is to understand that there was a difference in diagnostic yield. Secondly, on the right side, we also see that in this study, they wanted to understand if part of the ability to diagnose and treat and be effective around FH was a part of the GDP of the country and how much of that GDP was spent on healthcare. So I think sometimes we think about the robustness of the healthcare system as related to how much money you spend. And so here they looked at that. And here you can see that that's not the case. In fact, there were countries that have spent a high percentage of their GDP on healthcare. And again, that's indicated in the bright yellow, but did not have a high diagnostic yield. So it did not result in high outcomes and efficient system for diagnosing and creating impact with FH. And then you have countries that spent lower amounts. Again, here looking at the United Kingdom, they spent about a moderate amount of money on their GDP on their healthcare system, but yet they still had the highest yield from FH screening. Also, when we think about exclusion and inclusion, we can also think about other tools in other parts of our healthcare system. So here we have a study that's looked at ClinVar submissions. Now, ClinVar is a tool that's been created by the National Library of Medicine, and a branch or a part of the National Institutes of Health, which creates actionable variants or at all variants, and invites individuals from across the globe, and it can be institutions, individuals, to submit variants that they have found in individual patients, so to help improve the overall classification of variants, so that we understand in a mutation in a patient, whether that mutation is pathogenic, likely pathogenic, um, a variant of uncertain significance, likely benign or benign. So this idea that we have either certainty, we know that this causes disease, we know it doesn't cause disease, and then these measures of uncertainty, which include the VUS or variant of uncertain significance, likely benign and likely pathogenic. So they invite individuals from all over the world to submit their variants. And so for FH, when you look at familial hypercholesterolemia, variants that were specific to the FH genes that are LDLR, ApoB, and here they have PCSK9, when we look at the submitters by global representation, this is where they're coming from. And so you can see that most of the submissions were coming from the United Kingdom, Netherlands, France, Portugal, Spain. For many people in this audience, this is not a surprise. We understand because we also know where our registries are. We know the individuals that we've come across at individual meetings. And so this is not a surprise. And then you see quite a few from Canada, French Canadian populations are well known in USA, and then Brazil and other countries. But if we look at this globally, and here I've generated a map based off of what was published on this, you can see globally where the hotspots are for FH submissions for ClinVar. And if we break that down by the specific genes that they have, so sometimes in genetics, we often think, well, maybe there was a founder in a certain population. It's not represented in other populations. I don't know if that same case can be made. There's multiple founder variants and not necessarily founder genes, but you can definitely see an enrichment of certain mutations in different populations. But now let's look at all three of our FH genes, our classic FH genes. And I know there are a few others, but these are the classic ones that are widely accepted for clinical diagnosis. And you can see for LDLR, ApoB, as well as PCSK9, you have a very similar pattern. Now, the degree of submissions, so the number of variants that have been detected and different genes for these populations changes, but it's still the same continents, the same regions, the same countries that are being represented. And when we put all of this together, it's important to think of that was a clinical context, but now let's also think about global FH research. And here's a study that we've been working on looking at FH research across translational stages. Now, when we think about translation, I'd like to really sort of help you understand what we're talking about. FH, like all diseases, and the genes or the biomarkers we look at go through a translational stage, or sort of understood through a translational framework. We have discovery, which is what we call T0. T1 is when we first start looking at the biomarker in human populations. T2 is when we start to think about it in patients. T3 and T4 is when we're really trying to disseminate wide knowledge about these biomarkers in larger populations. And T4 is really when we're looking at global impact or population impact of the biomarker. So the whole translational spectrum from T0 to T4 becomes really important for our research. Here, I've done a graphical representation of FH research across all all five actually translational stages, including T0. And what we see is a very similar geographic representation. It's a little bit more filled in than some of our others, but you can see there's still very clear persistent disparities or sort of an inclusion pattern and therefore an exclusion pattern of where the information, our knowledge base, our evidence base for FH and FH biomarkers is coming from. When we put this together, and again, this is thinking about this in terms of the translational stages, and our first, in our sort of section A of our slide here, we have a pie chart, which shows sort of, it quantifies the representation of research that is coming across all translational stages and what region of the world they're coming from. And so for Europe, this is about 58.6% of all of the biomarker research for FH is coming from European countries, or is conducted on European populations. When we add to that North America, we can see that that's about 11% of the representation of FH research. Oceania, I know that it's a term that is not widely accepted, so I just want to help everyone understand that is New Zealand and Australia. It is a term that is indicated in the World Health Organization, WHO's classification of regions. And so when we include that, that's about another 2.3% of the world population that's represented for FH research. And then we have South America, about 5.5%, Asia, about 14.5%, the Middle East, 5.9%, and then studies that include multiple countries are about 1.8%. And so what we can see is that although there are a variety of different regions that are included, not all of them are included, and there's no equity in the inclusion of research or where the research is being conducted. We can also think about that in terms of the type of translational research. So in frame 2 here in our slide, we can see that the regional breakdown of FH research by translational category by country, some are focusing, the research that they do have, some focus more on translation into populations, which is the T3, T4, and some are focusing more on discovery, which is T0, T2. Again, we can also think about this in terms of the number of studies that individual countries are doing that are broken down to T0, T2, or T3, T4. And here we can see that overwhelmingly, most of the research is coming from Europe across both state translational categories. And that's more the discovery and really our knowledge or evidence base, but also our understanding of how to implement and do widespread screening, which comes more into the T3, T4 categories. So everything we know is coming from very specific populations. And then we've shown this in a variety of different ways. But I want you to look at the last stage, this last frame of our slide here, where we can see that although we have the breakdown by Europe, which is in blue, and red we have North America, I should say that most of the populations represented in the North American studies are primarily European ancestry populations. And then we also have Oceania. If we take those three together, essentially we have an overrepresentation of European ancestral populations in our FH research. And the reason I say an overrepresentation is that we've also looked at current world records that suggest that European ancestral populations are about 13% of the world population, right? So overwhelmingly, over half, more than half of the research, almost about 70% of the research is focused on one ancestral population. And who is consistently missing? Well, you can easily see it's from all of these geographical representations I've had. And there's a reason that I've transformed the research that has been done, including our own research, to focus on a GIS representation, because everything is gray, and these global maps and this world map shows who's not represented in the research, who's not represented in the ClinVar in submissions, and who's not represented in these large clinical trials that we're doing across the world. And so I think it's really important to see that in that global representation of it, to really understand the persistence of the problem, which is really about our evidence base. We talked about disparity. Now we're talking about the exclusion from research and the evidence, which is important to support the evidence base for going forward. Now, I talked a little bit about, or mentioned that I thought it was important to talk about structural racism. I think it's getting increasingly important to use these terms and these words that make us uncomfortable so that we can become more comfortable with it. And so one of the things I wanted to talk about is one of the things you might not have populations represented in your research is that it doesn't pertain to them. And though heart disease and mortality from heart disease may affect certain minority populations, it's not necessarily true that FH or FH variants would be inherently affecting heart disease in those populations. So we have to understand that, and that's just a part of our knowledge base and understanding our landscape. So here we have a study that was published that's looked at the carrier frequency of FH variants in African American and European American participants and the Million Veterans Program Study, here abbreviated as MVP. And the Millions Veterans Project is very diverse. It's one of the largest or the most diverse studies that focuses on biomarkers, precision medicine, and this translation of biomarkers into clinical practice. So it's a really great information base or a resource for us to use. And here we can see in the MVP study that when we look at the carrier rates for FH genes or variants in FH genes in the MVP study, we can see that actually for LDLR, African Americans had a higher carrier rate than the European ancestral Americans in the MVP study. And even though there was a substantially lower representation or a carrier rate of ApoB and PCSK9 carriers in this study, they weren't absent from the population. Furthermore, if we look at the table that is highlighted here, and this is a table from the study, from the actual MVP study, I want to focus on what we're highlighting here is the strength of association. So as an epidemiologist by training, I always get nervous that people only focus on the p-values. And I'd like to also think about the strength of association, which is captured in these beta coefficients. So here you can see that although the European ancestral populations abbreviated here as EA versus AA, which is the African American ancestral populations, essentially, you can see that their p-values are much higher for the European ancestral populations. But you can also see that the sample size, the number of the, persons who identified as European American was also much higher. So you would expect the p-values to be stronger. But when you look at the strength of association, you can see that there's a persistence and even stronger strength of association in the case of LDLR for African Americans. And the reason that beta coefficient or the strength of the association matters is it means that there's a strong correlation or association between variants in FH genes in African Americans and high LDL levels. And so when we think about whether they should be included in research, whether the exclusion is because biologically it's not relevant to this population or it's something else, I want to point out here that we've shown, or this study shows, that there is a strong association in this population too. So there's really biologically no informed reason why African-American populations shouldn't be included in the FH research, right? So when we think about structural racism, I want to think about it in this terms. I've often been quoted as saying equity as an afterthought is inequity by design. And I want to think about structural racism as our design of what we do. And that affects all of the areas in terms of health, all of the systems by which individuals have to interact and influence our health. So when we think about design and we think about structural racism, if we're not thinking about equity when we're building our systems, we will have inequity at the result, or we shouldn't be surprised by it. And so when we think about just in context of what that means in terms of structural racism, and again, so this is not personal bias, this is not something I'm intentionally doing to any one individual. We all exist in these systems. So a system in which public policies, institutional practices, cultural representations, and other norms and various offers ways to perpetuate racial group inequity. So what this means is that we actually don't have to be aware of the structural bias in order to participate in a system that is perpetuating structural racism. And so if we want to combat that, we have to make ourselves aware. And we also have to be thinking about equity at the forefront, not as an afterthought. So we need to identify the systems that are perpetuating these biases: medicine, biomedical research, as well as the public policy and public health systems that we build. We need to be thinking about how to make things equitable. And that is why this session today is so great, because it's an opportunity, and essentially precision medicine is still something that's new. So we're still, building it. And so this is an opportunity to build a system which can have more equity and improve outcomes for all Americans and all persons globally, especially in the context of this. We're talking about building better better outcomes for patients with FH. So change. And here in change, we're thinking about what is needed to improve inequity. Well, the key is transformation. We need to work to transform our systems. And how do we do that? We need to confront the problems. That means we need to be aware of them. We need to have a full landscape of what's going on by disease area. So here we've thought, and I've tried to show in terms of research, the landscape of FH research and where the gaps are. And we have to face the difficult conversations. We have to not shy away from the things the things that make us uncomfortable. And we can't always expect the disparity or the equity work to be something that's niche for other people to do. We need to bring it in and incorporate it to what we're all doing. So what we're all doing, that means we need to include all people. We need to have a workforce that is diverse, that understands different aspects of our population demographics, but also different aspects of sort of our knowledge sets. And so we need to build a system that actually encourages workforce diversity so that there's more inclusion. And then also, what we need to think about in terms of building this is actually how we build, how we transform the system to have structural integrity, right? And so we need to invest in that system. How do we create structural change? We need to invest in it. It costs money. And so here's an idea that we can work on that I think is particularly important for building equity for FH and for the FH Foundation. So equity-based precision medicine frameworks, where do we start? And that's what we're talking about today. And so here is a representation of the global FH registries that was published recently. And so here you can see by regions of the world that a lot of regions are covered. But again, the geographic representation really allows us to know where we don't have the investment or the infrastructure that's necessary to really understand our baseline. And understanding the baseline is important for understanding how we can improve. Right. And so just starting here and just looking at this, you can see that very clearly across Europe, we've done a reasonably good job of covering Europe in terms of FH registries. And I think registries are really good a component to really to building a knowledge base around the landscape. But there are persistent areas, although South America was represented in some of the research that we've seen in some of the ClinVar submissions and the clinical trials that we looked at earlier. There are parts of South America that were not included and are persistently not included. And then also Central America is almost never included. And we need to think about that. Additionally, we have the continent of Africa. And I just want to look at that. The continent of Africa is large. It is much larger than Europe. However, we have very little infrastructure, very little investment by the way of FH registries in that continent. So that's an area that we can improve. We can improve by investing in building registries and collaborating with partners in those countries to build those registries so that our knowledge base can be more inclusive. And then lastly, in Asia, it's important to understand, again, there are parts of Asia that are often represented, but there are parts of Asia that are often excluded. And so really understanding this and understanding this from a landscape and even from a geographic representation, really helps us think about where we can start by investing in building infrastructure in those areas. So we talked a little bit about disparities, we talked about exclusion, we talked about structural racism, and we talked about change. But I hope the biggest thing that we've gotten from this is that we can build equity. And I think that's really exciting because with precision medicine, the investment is now. There's a lot of investment in our current time frame for how we build the foundation and the infrastructure for precision medicine going forward. And I, for one, am extremely excited that the FH Foundation is focusing a whole session just to talk about how we can do this for familial hypercholesterolemia, which is an important disease in thinking about, and not just thinking about for FH patients, but I also think that FH is really something that can be the template for how we move forward for other rare diseases. Systemic transformation is what we need. And I think from that, if we invest in that, we can create change. So with that, I'd just like to thank my collaborators and also the FH Foundation for the invitation to share. And I look forward to your feedback in the ongoing panel discussion.
Thank you so much, Dr. Landry. That was a fantastic talk, and I know that there'll be lots of questions in the panel for the panel discussion, and we'll do that in just a little while. I would remind the audience that if you have questions, to please post them in the Q&A session, and we'll keep track of those. And we also have a few questions of our own for Dr. Landry, of course, as well. I would like to continue the program now. We're going to hear from Dr. Zahid Ahmad, who's an associate professor in the Division of Endocrinology at UT Southwestern. His clinical and investigative focus is on lipid metabolism disorders, including dyslipidemia, chylomicronemia, and of course, familial hypercholesterolemia. His research aims to identify the causes of cholesterol and triglyceride disorders and to develop new treatment options for those patients who suffer from them. He's been funded by the National Institutes of Health, and his colleagues are currently working on identifying families with these conditions, especially in groups not traditionally, that are traditionally underrepresented in such studies, to better understand their genetic causes and improve their outcomes. So thank you so much, Zahid. Well, welcome.
Thank you all very much for having me. I really appreciate this opportunity. Let me pull up my slides. So I'm glad that Dr. Landry was very positive, because I'm going to talk about the known inequalities for familial hypercholesterolemia, and this might be a little bit more doom and gloom. So I'm going to start by talking about diagnosis of FH and potential disparities, genetic testing, and the evolution of that in minorities. And then a lot of my time will be focused on treatment. And what I hope to get across today is that the major issue that we're dealing with is that treatment inequities exist, and we're not making much progress to close the gap. So I wanted to just start with one introduction slide. Dr. Landry really introduced this whole topic outstandingly, but I want to just mention what I consider as a disparity. I consider it as a quality of healthcare problem when comparing different groups. And in this graphic, this compares non-minorities to minorities. The reality is that racial, ethnic, and sex disparities exist, and because they're associated with worse outcomes, they're unacceptable. Now, the most common question I get when I've shown the data I'm going to show you guys later is this because of patients? Is this non-adherence? Are they just not taking their medicine? And based upon several studies from the late 90s, that doesn't seem to be the case. Patient non-adherence and refusal rates are generally small and do not fully explain healthcare disparities. What does are the things that Dr. Landry kind of pointed towards: issues with healthcare systems, legal regulatory climate, discrimination, the biases, the stereotyping, the systemic racism that exists, unfortunately, in the system. So let me first talk about diagnosis. And we wanted to know whether or not there's actually a disparity in who's getting diagnosed. Are minorities getting diagnosed with FH less than non-minorities? And so the FH Foundation and Kelly Myers and his group were able to pull data to kind of predict who may have FH. And we don't see huge differences. Though really the only difference here is that Blacks and African Americans got an ICD-10 code 11% of the time, whereas we would have predicted it to be 12%. Now, because of the large N's here, that is statistically significant. In terms of genetic testing, as Dr. Landry referred to, efforts in the past, especially in the 2000s or earlier, for genetic testing have been pretty much limited to just a few countries, mostly in Europe or in Japan. and in well-studied subpopulations like South African white Afrikaners, Christian Lebanese, French Canadians, Ashkenazi Jews, and Old Order Amish. So in Dallas, we had decided years ago that we would focus a little bit more in multi-ethnic cohorts. And luckily, we have several lipid clinics, and we were able to recruit patients, including a very large number of African Americans, to do genetic screening. And all of these are individuals that we clinically diagnosed as FH. What I show here is a schematic of the LDL receptor and all of the mutations that we identified in the LDL receptor in our cohort. Our cohort is currently about 400 patients big, or 400 patients in it. And this is color-coded. These mutations are color-coded by ethnicity and race. And so you'll see that the mutations occur throughout the gene. There's no particular pattern with regards to ethnicity and race. What we did learn, though, is that we could identify new variants, new pathogenic variants in the LDL receptor by studying these minorities, especially in African Americans. Another thing we learned was that we could reclassify variants. So we found variants in the African Americans that had been previously categorized as pathogenic, but we found them in too many African Americans. And then when we looked in non-FH African Americans, we found that those variants existed in them at a high frequency. So it was not possible that those particular variants are disease causing. And in fact, what had happened was that those variants had only been studied previously in European populations that did not have, and those populations did not have them very frequently. So we were able to reclassify those pathogenic variants as non-pathogenic. So this goes towards a lot of the things that Dr. Landry was saying. There's a lot of benefit in studying multi-ethnic or different ethnicities and races with regards to genetics. The hot new thing in the genetics world is this idea of polygenic risk scores. And for people in the audience who may not know what that is, traditionally we talk about one mutation in one gene causing one disorder. The other model is that there are many mutations or variants in many genes that by themselves don't do that much, but in aggregate, they can cause something very similar to the one gene, one disorder type of model, the monogenic model. And the polygenic risk scores are being developed for quite a few different disorders, including high cholesterol. And in some patients who have FH will have high polygenic risk scores. The point in this slide is that for African-American patients, polygenic risk scores still are not defined. And there is work being done to kind of close that gap, luckily. And let me move on to treatment. So just so we're all on the same page to start with, I wanted to just review very quickly what the guideline-based treatment for FH and patients with high ASCVD risk is.
Yep, Zahid, unfortunately, we've lost your audio. It's possible that one of us could present some of these slides if you want to scroll through. These are data that I know very well, and Zahid really led this effort from the FH Foundation's CASCADE FH registry. Dr. Landry showed a beautiful slide of registries around the world, and unfortunately, that specific project did not encompass the work that we've done at the FH Foundation in Cascade, which now has several thousand individuals in it. And the data has been invaluable. And one of the first things that we showed was that there are inequities in achieving LDL goals. Both women and individuals that are non-white European have a harder time and are less well controlled. Why don't you go to the next slide there? And that's really displayed here. Women are 40% less likely to be on a statin, including a high intensity statin. The reference is shown here. This was published in Atherosclerosis a couple of years ago and really highlighted the systemic issues we have in terms of sex treatments across sex.
Josh, can you hear me now?
I can hear you. I've just presented this slide, so maybe go to the next one.
Sure. So I could hear Josh presenting the slides. He did a great job, probably better than I could do. So this is similar data to men versus women, except this time we stratified by ethnicity and race. And let me unpack this for just a second. What we're looking at here is enrollment data to the Cascade FH registry, and then follow-up data. And on enrollment, you'll notice that enrollment is in red, that African Americans and Asians achieve LDL goals of less than 70 and less than 100, less often than European ancestry individuals. And on follow-up, the good news is that everyone is better. Certainly we're getting more people to goal, although still we're doing quite poor in how many people are getting to goal overall. But these disparities maintain. There's still a gap. Still, African Americans and Asians are not getting to goal as often as European ancestry individuals. And so this is my last slide of data, and this is data again provided by the FH Foundation and Kelly Myers and his group. Again, claims data for people who have had the ICD-10 diagnosis of FH, looking at how many people are getting the treatment with statin plus ezetimibe plus PCSK9 inhibitors. And again, that's the guideline recommended treatment if needed to get LDL below 100 in primary prevention or below 70 in secondary prevention. And you'll note that regardless of how we divide the data, whether by sex, ethnicity, race, education level, or income level, there are clear disparities. Men get prescribed these drugs more often than women, Caucasians more than African Americans, Hispanics, people with college education more than high school education, and people with high income more so than less income. So in summary, racial, ethnic, and sex disparities and inequities exist for individuals with FH, and because they're associated with worse outcomes are unacceptable. Previously, genetic testing and screening and polygenic risk score development was done mostly in European ancestry individuals, but efforts are underway in more diverse populations. Major disparities exist with regards to achieving LDL cholesterol goals, and as we improve overall treatment of individuals with FH, the disparities and equities gap persists. So further efforts are needed to improve awareness and design interventions to reduce these disparities and inequities. I'm really looking forward to hearing the panel discussion in just a few minutes.
Thank you so much. Thank you so much. So that's a great discussion and will really be important when we unpack it during the panel discussion. We are going to have two other individuals join us for that panel discussion, and I'm going to introduce them in turn. First, let's hear a little bit from Ms. Barbara Harrison, who's an assistant professor at Howard University and teaches graduate students, medical students, and medical residents in the areas of genetics, genetic testing, genetic counseling, and ethics. In addition to her academic duties, she provides genetic counseling services at Howard University Hospital across the spectrum from prenatal to pediatric and adult genetics. She's the Assistant Director for Community Outreach and Education at the Howard University Center for Sickle Cell Disease, and was recently awarded the 2020 National Society of Genetic Counselors Natalie Weisberger Paul National Achievement Award, which is the organization's most distinguished honor. So thank you so much for joining us, Barbara.
Yes, thank you so much for inviting me to be part of this panel. And I'm looking forward to the discussion later for sure. But I just wanted to take this time to discuss some of the issues around genetic counseling for FH, particularly in diverse communities, and some of the things we need to be keeping in mind. So of course, genetic counselors assist in making a diagnosis of FH, promoting patients' understanding about how FH affects their health and how it's inherited through families. We often coordinate genetic testing for patients and identify other family members who are at risk. We provide strategies to help with communicating information about FH through families, within families, and then through CASCADE testing, we can facilitate and coordinate that testing for them. So I'd like to just take a few minutes to share my thoughts on some of the genetic counseling and clinical testing issues as we continue to strive to have people of all backgrounds be able to benefit from some of the medical advances for those with FH. So as has been discussed by Dr. Landry and Dr. Ahmad, there have historically been a lack of efforts to ensure ethnic diversity in FH genomic studies. And so unfortunately, this translates to certain groups of people receiving genetic test results that are often uninterpretable or uninformative. And we know that identification of those with FH through genetic testing is critical to our efforts to decreasing the risk of significant cardiac disease in these individuals. And so having a lack of information about those genetic variants in these undersampled populations has led to significant barriers in these communities really being able to benefit from the advances in treatment. And we can anticipate to, all of the potential promises of personalized medicine and personalized health. And we can really draw from experiences that have already happened within genetics, particularly in clinical genetic testing for cancer, where there's a similar phenomenon going on, where the rate of variants of unknown significance, so variants that we had never seen before, had been described before, were being seen in higher incidences in those from communities that have been excluded from, genomic studies that help to develop that evidence base that has been talked about already. And so we know from experience that this can lead to misinterpretation of what those variants mean to a person's health, and resulting frustration and even disengagement from the genetic testing process of those from those communities. And so it is really, a conversation is extremely important. And we need to actively address these disparities and discussions as we really seek to reach everyone who can benefit from early identification and successful management and treatment of this condition. So how can we really achieve this diversity and resulting equity in genomic research? And the good news is that there is certainly evidence and promise that's there. And so we can build on that. I think one of the main points is full engagement. This full engagement really is key. From the beginning process of developing a research protocol, it's imperative that representatives and experts, medical experts, research experts, experts in epidemiology, that these individuals are coming from the communities of interest and that they are at the table from the very beginning, taking an active part in the development, implementation, outcome assessment, and evaluation of the project. There must be an investment and a commitment to the community that we're trying to reach out to, those communities, to those countries that we're trying to reach out to, that they will reap the benefits of that knowledge gained from the project. So just kind of reaching out and trying to include individuals from diverse populations in a research study, just so you can check the box to say that this is something that you've done. This is really not enough. This is not the approach that, that is going to lead to significant change. Instead, and we know that taking that approach can lead to mistrust and just further perpetuates the bias and the racism that we're really trying to avoid. And so as we try to think of ways that we can approach this in a different way, we need to remember that it's not just about including these communities in the planning of these projects and in addressing these genomic study disparities, but also disparities in the access to quality healthcare, and Dr. Ahmad talked about that quite a bit. So I've done some work with the sickle cell community just over my time in genetic counseling. And just to quickly say, sickle cell disease is one of the more common genetic diseases in the world. And one of the challenges that we often have is identifying individuals who are carriers. And so these carriers would then have a subsequent possible risk to have a child with sickle cell disease. And similar to FH, a common strategy that we take is to test family members of those who are affected or known to be carriers. So in order to identify others who may be at risk, and in other words, taking this cascade testing approach that is commonly done in FH as well. But the key to that approach is having access to appropriate testing. And I think it's important that we think about focusing advocacy efforts on that issue around ensuring that individuals who are at risk really have access in a way to get tested and to have quality test results, of course. And so this includes educating healthcare professionals, and this is something that we have dealt with as well in our sickle cell world. But as I can definitely see evident in FH, where you have health professionals that are not familiar with the condition. We know the condition is drastically just underdiagnosed or misdiagnosed. So educating healthcare professionals is key, as well as reaching out to third-party payers, including government payers, because we know that this is often the gatekeeper of who gets what test. What is my insurance going to pay for? And if it doesn't pay for it, then I'm not going to, be able to take advantage of it. So we really need to make sure that those issues are addressed, and we need to advocate in those areas. And so I would say, lastly, we want to encourage everyone to share their family health history. And this is a challenge for all of us. Some people are very open about their medical issues, others tend to be very private, but we know that this can be to the detriment of other family members. And FH is just a classic example of that. So any campaigns that can assist with the communities that we're trying to serve to understand the importance of sharing their family health history, of removing the stigma that might be associated with that, is a topic that many advocacy groups in genetics are struggling with. And so this may be an opportunity for collaboration with other advocacy groups around this topic of just discussing, encouraging people to share this information within their families. And that those efforts can be not only with genetics advocacy groups, but also just groups that focus on minority health. You know, we can broaden our scope outside of our little silo. And, you know, by doing that, we can engage even larger areas and larger segments of the community to help bring this to truth for everyone. So with that, I will pass on the mic, but look forward to further discussion.
Thank you so much. That was a great, and we look forward to hearing some more lessons from your work in the sickle cell space, et cetera. The last person, very important person I want to introduce before we begin the panel discussion is Ms. Chloe Villavasso, who's an adult health clinical nurse specialist and holds a clinical faculty position at the Heart and Vascular Institute of Tulane University School of Medicine. Her interest in cardiac nursing started with the diagnosis of high cholesterol and a family history of premature cardiovascular disease, something that we hear all too frequently. Chloe is a fellow of the Preventive Cardiology Nurses Association and serves as the president of the Crescent City, New Orleans chapter. So thank you so much, Chloe.
Thanks for having me. I'd like to start by letting you guys know that my journey with high cholesterol started when I was 8 years old. There was a group that came to my elementary school and they did cholesterol screenings. And I remember being told that my cholesterol was high. And the other thing that I remember from so long ago was that I could have a heart attack when I was 30. So those were the two things that I took away from that screening. And at that time, I thought that a heart attack meant that I was going to die. So for a good amount of my life, I thought that I was going to die at 30 years old. So after the screening and I found out that I had high cholesterol, I would go on Saturdays to the Children's Hospital here in New Orleans, and they would ask me questions about my diet. And I remember at the last meeting that I had, it was determined that my diet was not the cause of my high cholesterol and that it was because of genetics. So I was like, okay, great. What now, right? So as time went on, I learned of family members who had heart disease and who had passed. My father's dad died at 59. He had heart disease. My mother's dad had a heart attack at 59. And then my father, he suffered a heart attack, received a stent at 51. So that made a pretty big impact on my life. And I decided that I wanted to become a cardiac nurse because I always wanted to be knowledgeable of the treatments and drugs that would be available to me, because I figured that it was a pretty high chance that I would be a cardiac patient one day. So then from there, I talked to my PCP at the time and inquired about medications. And she told me that they were not prescribing medications for people until they reached 30. So that was a bit of a blow because I was afraid. I said, I want to get treatment. I want to get these numbers down. Then she ended up starting me on a statin, but then I started having kids. So I was on and off medication during that time period. When I had my last son, I was 29 years old. And when I was done breastfeeding, I was ready to go. I said, I'm gonna get on a statin. I'm gonna stay on a statin the rest of my life, get my numbers down, decrease my risk of having a heart attack. I go to the PCP I was seeing at that time, and he told me that he wasn't going to put me on a statin because the only risk factors that I had was high cholesterol and family history. And he said I didn't have high blood pressure, I wasn't overweight, I didn't smoke. So he didn't want to put me on anything. So I was really disappointed when I got that news because I knew my family history and I knew I needed to be treated. And I wanted to be proactive in preventing a cardiac event. So I then decided to see the cardiologist that my dad was seeing at that time, which happened to be a physician that I had worked with for 10 years. And I referred my dad and my dad's brother to him. So he was very familiar with the family history. And I felt that I had a really good chance of him understanding the treatment that I was seeking. So when I saw him, he told me, he said, Chloe, I know what's going to happen if we don't do anything. He said, I know your dad, your uncle, who both ended up with bypass surgery. And he said, I'm going to be aggressive with you. And I told him, I said, that's totally fine. So went through 3 statins. I'm on my 3rd one now that I can finally tolerate. It's not one of the stronger ones, but at least it's something. Numbers still weren't where he wanted them to be. And so he then added ezetimibe, and we got some better results with that. But as time passed, even more family members suffered heart attacks. I had a first cousin, which was my dad's brother, the one I mentioned, that had bypass surgery. His son at 39 received a stent to his LED after suffering an MI. And then his sister, a month later, had an out of hospital arrest and died a couple days after she arrested. And she did have severe PAD. I don't know all the details, but I do know that she did have PAD pretty badly. And I do have a nephew who, at 4 years old, had an LDL level of over 300. And he has since started on atorvastatin, and he's been on that for a couple years now. So it's been quite a journey for me, getting the news at 8 and thinking I was going to die at 30. And then I wasn't given much information past that, like what's next, what do I do? And I spoke with my father about it, and he didn't recall getting any information either. It was kind of like we were just hanging out there, with this information. So I really am thankful for the FH Foundation and the work that you guys are doing, because it's really important to get the information out and let people know that screening is important, treatment's available, genetic testing, things like that. So I think that what's been highlighted in the other talks is key, because we have to reach all populations, and women, Blacks, Asians, everybody should have the same access to healthcare. So that's pretty much my story and my journey with cholesterol and FH in my family.
Thank you so much. That's such a powerful story. And before we bring all the other panelists in, we'll ask you to, show, I think we'll ask you to show your videos and unmute yourselves. But Chloe, I wanted to ask you right while we have you on, that's an extremely powerful story. We hear so often of missed opportunities, lost opportunities to prevent, deleterious outcomes. And, you talk about engagement. You're bought in. You're a nurse. You're able to communicate it. You're embedded in a community that is at high risk. Was there any reluctance within your family or the patients that you see to be treated for this? And if there is reluctance, what strategies have you used to overcome that?
Not so much in my family, and I think it's because of the great loss that we've suffered over the years, with first losing my grandfather so early. So my family, they know that we have to do something about it. But as for patients, yes, it can be quite disappointing for me, because I do come across a good number of patients, particularly younger people, that don't want any treatment. They want to try exercise, they want to try, diet, and which is good. but the approach that I usually try is I let them do that. And, you know, even with having the family history and, you know, I tell them, let's try diet, let's try exercise. I go into detail with them and I say, let's test again. Okay. And they're like, okay, yeah, let's test again. And then that way they've bought into the process. They know that they have the power to first try what they want. You know, we do that and we come back with numbers after they've tried diet and exercise. And then some of them say, okay, yeah, I see that I need to do it. So I think it's just really important to meet people where they are, give them the information, meet them where they are, and then, you know, keep going from there and trying.
Thank you so much. Then next I want to turn to a question for both Zahid and Barbara, which is, you both touched on this, and I thought it was so important, the idea of trust and you know, being embedded in the community and long-term investments being needed. You know, so many of us, we see a problem, we want to solve it. You know, we see a family that's affected, we want to, you know, fix it right away. And unfortunately, that doesn't seem to always work. You know, Barbara, you said we really need a long-term, you know, investment. We need long-term, you know, trust to be established. And Zahid, you know, you've been studying something that's really hard and yet have managed to engage a lot of individuals that might not have participated in clinical research trials and really, you know, your slide showing that the failure to engage, you know, Black patients in research not only affects those Black patients, but has really important implications for the rest of us. So in the spirit of trying to move forward, how do we establish that trust and engage and do the hard work that's needed, you know, to bring about change? So maybe I'll ask Barbara first, and we'll see how if Zahid's, you know, internet connection gets more stable. So you'll have to unmute yourself.
All right. So yes, I think it's important to understand the history that many of these communities have experienced. Oftentimes their involvement in research has led not to the benefit of themselves, but they see it turn into a benefit for others that you know, were not necessarily involved with the testing, or, you know, more importantly, they see that someone comes into their community, does research, and then leaves, and, you know, and never comes back. There's never any follow-up. There's never any continuation of that relationship. And that's just been the history. And I think everything that we can do to show that this is a new day, that we're coming with new intent, is what's going to be key. And I think the way to demonstrate that is, again, from the beginning, engaging people from the community in that research project. And it's, you know, there are individuals who are African-American, who are African, who are from Central America, you know, who have expertise that we can tap into. And that's only for the benefit of the project. I mean, I think it's also an important concept and to capture that diversity leads to excellence, right? And so if you have diversity in your research team, that's only going to make your research project better. Not only because of who you'll, you know, potentially attract to be your participants, but just the way that that data is assessed, how people think about how to analyze the information that comes out of it. Again, the outcome and the evaluation of those studies. But I think the way to do it is just that full engagement. It's that, you know, inviting individuals to the table from the very beginning and maintaining those relationships and developing relationships with organizations in that community, health organizations in that community, social organizations in that community.
I mean, I can think of one organization that's going to be amazingly trusted, which is the sickle cell treatment centers. I mean, that's a group I would imagine that has established a lot more trust than many other groups. I'm sure we can learn a lot from those centers.
Well, you know, and that has a history as well. You know, there at one point there were, you know, several federally supported sickle cell treatment centers. That is no longer, you know, that federal funding was taken away in the earlier 2000s. So now it's just, you know, individual hospitals that decide to devote funds and staff to, you know, make those centers work. But showing that commitment then is what shows the community, okay, these individuals are really invested in our health. And so that's why those centers have succeeded. You know, it's unfortunate that's the way it had to happen, but, you know, in the end, and those relationships are there.
Right. Zahid, maybe you can touch on that briefly with some of the strategies that you use for engagement and showing and building trust.
Yeah, Josh, can you hear me okay?
Yes, we can hear you.
Okay. So a lot of the things that we have done in Dallas, not that we're some kind of model for excellence, but a lot of the things do resemble what Barbara had described, and there's not too much more I can add to it. You know, we've made sure that our research team is diverse so that, you know, the patients, the research subjects could feel comfortable. We make sure that, you know, we understand our own biases, because a lot of the problems actually happen in the patient-provider or patient-researcher interactions. And so we try to understand what our own biases are. We've done some bias reduction training. You know, those kind of things help, but to solve the overall problem is extraordinarily complex. It occurs at so many different levels, and it'll take a lot of people a long time to restructure everything. Although I think that should be the goal. But I think that's kind of, you know, we just kind of take things one thing at a time, try to bite off small pieces of the sandwich until we can eventually get the whole sandwich.
Thank you. Now, Latrice, you know, I loved a lot of things about your talk, and I'm just going to pick up on two themes. One is that we need to become uncomfortable. We need to become comfortable being uncomfortable, and that also every challenge is an opportunity. Every challenge presents an opportunity. And when I saw your slide showing the distribution of FH research, I mean, the whole continent of Africa is essentially absent, even though we know that, you know, for instance, PCSK9 variants are prevalent at a high prevalence in certain African populations and played a key role in the development of those therapies. And so what I wanted to ask you is you had some ideas for what we need to do next. If we had, you know, we could give you a magic wand and give you $1 million or $2 million or something. What would you invest in, you know, to take, you know, the next steps? What would be the most top 2 or 3 things on your list?
Josh, thank you for your question. I think one of the things I think is really important to understand, and I was really excited by Zahid saying that my talk seemed very uplifting and positive because his was more doom and gloom. I think those two things go together, right? And I think you picked on that, Josh, exactly. The idea is here, there's a lot of opportunities. And so I do see it as a positive because I think that we need to create that space as someone who feels like I could benefit from precision medicine. I want to make sure and be a part of the system that helps build it so that I can, so that my children can. And so I think that that's important. But what can we do? If we were given $1 million or $2 million, what would be the clear priority for doing that? And I think part of this is why the landscape, as I mentioned, is so important, because what it clearly tells us is where we haven't invested. And I think in all of the talks, what we've heard and talked about was infrastructure. What we never talk about in biomedical research or even in clinical practice in our day-to-day is how the infrastructure that we work in, how the systems that we work in impact our ability to function. And I think the key here is we have to be uncomfortable because transformation requires difficult conversations. We have to know what needs to be changed, and we have to be courageous and clear and decisive on our intent to change it. So what does that change? Well, you mentioned the entire continent of Africa is missing in our FH research across translational stages. So that's discovery of any potential new variants that could cause FH or new genes that could be important or contributory, or things that could modify the relationship between a gene and, you know, sort of the genotype and phenotype. I'm a geneticist. I must try to stay away from that jargon. But the two things, the exposure and the outcome, the things that modify that relationship, as Chloe sort of talked about in terms of her experience in her own course, she was first talked about diet. The first intervention that was suggested to her was about diet. And I think that's important. Its diet is a huge contributor to heart disease. But for an 8-year-old with high cholesterol as a geneticist, I'm like, oh, that's definitely not dietary. That's not, environmental. But here we have this disease in FH, which is both has genetic components. It's definitely modified by environmental factors. What do we need to do? We need to embrace complexity, be uncomfortable, build a workforce that actually can help us reach the communities that we need to. And that workforce cannot essentially just be diversity in our recruitment and our engagement. We need diversity in the leadership, diversity throughout the infrastructure. And then we need to engage those patients. And honestly, what we see now is where we should invest that money needs to be at the populations that are completely excluded. If we think about it from this standpoint, and I think this is you might have seen those, I thought about including one, but these little cartoons of a family or people watching a baseball game from behind a fence. And there's this idea that equality is everyone gets, that you have the person who's 4 foot tall and the person who's 7 foot tall and the fence is 6 foot tall. Equality says we all get the same box to stand on to watch the game from behind the fence. And then when we think about equity, maybe the 4 foot tall person needs a bigger box to stand on, whereas the person who's 7 feet tall may not need a box at all. I think that's important to think about when we think about equity and investment, because right now what I see is that we clearly need to invest in the communities that we haven't invested in. That doesn't mean we withdraw from the other communities. We need to maintain, monitor, build, and maintain the infrastructure and enhance it. However, the greatest investment right now needs to be in the communities that are largely without. And so part of that is just landscaping, understanding, again, this is how our T3, T4, understanding implementation science and the barriers to implementation of successful strategies in those communities is really important, and invest there, and then build the system that allows us to be successful in those communities and optimize the rest of the system with what we learn from that. And so that would just be sort of my quick highlight of where I think we need to do, but it starts with investing where we have traditionally not invested.
Yeah, that's great. And I have slightly more optimism after hearing from powerful leaders like you on this call, to be clear, I think that, the FH Foundation is clearly committed to trying to increase, diversity within our research efforts. Cascade FH, I think we showed you some of those data Zahid did with cataloging the disparities there, and also with our new efforts in Find FH, we're certainly exploring ways to increase, outreach to populations that might not have been diagnosed previously. I think we had one question from the panel from the Q&A, which I'd like to ask and that is, one of the big problems with FH is that, as you highlighted so well, Chloe, people are not diagnosed until it's too late. Obviously, they've already had an event. What do we know about screening, for instance, in pediatric populations from non-white European populations in the United States or elsewhere? I would imagine that it's pretty bad in white European populations. It might be worse in other populations. Do any of you have any idea about that?
Yeah, so I will say that one of the things in Chloe's own story, the whole idea of taking lipid levels in kids at school is a popular screening strategy for elementary schools. I hear it sort of proposed all the time in terms of how to do implementation of FH screening specifically. And so it's interesting that it didn't result in a sort of different outcomes in terms of how people were thinking about her high cholesterol levels as a child. I think what I will say is from what I've seen on the research standpoint, there's an absolute absence of research in American minority communities on successful implementation strategies for screening. And if we think about how screening happens, how broad-based screening happens, it usually comes from one of two directions, right? So we have the European model where as a country, as a nation, we decide we are going to screen everyone, right? And we want to create these large national registries because it is something we're passionate about. That would be great if we had a national commitment to thinking about that. However, the other ways in which we think about screening is really from these, I would say grassroots, but they're investigator-led research initiatives that, sort of test and model how you would do screening in the population. And I think that's something that is easily, we can intervene upon, because for our research, in terms of clearly focused, targeted screening programs or research focused on either genetic screening by genetic testing, or screening by or phenotypic screening through lipid concentration quantification. I think the issue is that there wasn't research in minority communities about how to do it. Right. And so really sort of thoughtful implementation research about how to do it, which would suggest without a national approach, that even if there was a national approach, we might miss how to do that in those communities, because we have other implementation studies that really suggest how we should do screening in majority white populations, but we're not capturing how to do it in minority populations. And I know we've focused a lot in minorities about African Americans, but we also have to think about how would that translate to tribal nations? How would that translate to Latino communities or people who might have English as a second language or may not be English speakers at all, if we want to have this comprehensive inclusion? And so I think we need to first invest in research in that area of really thinking about minority communities. But as a geneticist, I have a plug for doing genetic first testing, not just for my own personal interest, but I do think that in terms of bang for the buck, right now, you could perceive of FH screening being a part of a national, more comprehensive, expanded genetic screening test. Right now, we have newborn screening, and that includes a very select a set of usually pediatric onset conditions, but you could think of, and I think there's a lot of things that go into why we do just pediatric onset conditions and so what goes into that, but we could think of another timeline where FH and other disease could be screened for closer to the time where, or adult onset, where the time they're thought to have their impact.
Wow, I love those ideas. I think you came up with like 2 or 3 RFAs there that we should write and respond to. That's really great. The conversation has been so wonderful. I've lost track of time, but I've been told we're now at the end of our time. Please, we're happy to continue to answer questions through our newsletter or blog. So if there are other questions, please send them our way. And I'd like to really thank all of you and all of our panelists and all of the audience. Over 200 people tuned in to hear us today. So thank you so much for spreading the word, and join us next time for the next installment in the FH Global Summit 2020, which will be on Thursday, November 22nd, and will include a keynote address from Kevin Bolt from Penn Medicine on behavioral economics driving cardiovascular disease prevention. So thank you, everybody.
Thank you.
Thanks.